days. I wanted to thank our team, and I'll just point them out to you. Maybe you can see them on the screen or maybe not, but this was the team that was talking about all of you and thought we really ought to have a session where our coordinators and managers and people that are really on the very front end of managing access to ECMO equipment, staffing, regional coordination, all of those things, had an opportunity to talk with each other and share what they're learning, maybe even also ask for help or ideas for things that you might still be struggling with. And that team, I won't be able to point where they are probably on your screen, but I'll just say their names and maybe they can wave to you when I say their names. But Peter Reich is probably famous in the ELSO world. He is ELSO. When you think of ELSO, that's Peter. So we're working on a new brand where it's just his head in the background, you know, for people. So Peter Reich is our long-serving executive director. Liz Moore is she's been with us a long time, but she is our new education director, and we're very excited to have her formally in that role. That means we get some of her dedicated time every day, so we're lucky for that. Kenethia Banks, you probably know if you've been in the education space at all or need to do anything with a bill or transaction, you know Kenny. So we're lucky to have Kenny with us, and she also was thinking we really ought to benefit from having this conversation. Alex Fox is a new project manager with us and just joined us this year. He's everywhere, so if you don't know him yet, you will soon. And last but not least, our Layne Cooley, who probably many of you know too. She's a longtime nurse from Michigan who treated ECMO patients for over 30 years. She's been with us a couple years now as well, and we're so lucky to have her. So Elaine, if you want to wave to everybody if they can see you. But that's our team that really had this thought and idea. And of course, Velia is in the background here, but everything that you see in the social media world, Velia's had a hand in. So if you are ever thinking who's the genius behind making some of these complicated things look simple and interesting, that would be Velia. In addition to just keeping us all apprised on what's happening in the paper and publications world, Velia does an enormous amount of work for ELSO to just keep ELSO present in your mind. So thanks to Velia. Our panelists today, I'm just going to say your names real quick, but then I'd love for you to kind of go around in that order and just give everyone here on the phone a little bit more in-depth introduction of who you are. So we have a great group of people that have agreed to be panelists for us today. That just means that they're going to start us off in the conversation and share some of their own experience. It doesn't mean that they know all the answers and all of that, and hopefully they get something out of this today too, where we all get to ask each other questions. So we have Tracy Lane, Jen Crumley, Mike Kotwas, Tammy Frederick, Kelly Toynton. I'm not sure if she's on or not. Hopefully she is. Bernadette Elliott looks a little different. She looks like Phil Mason today. Unfortunately, she wasn't able to join us, but you know. So Phil's taking her place, and then Ethan Kurtzman. So if you all might want to go through and just say a little bit more about yourselves to start us off. Thank you. Tracy, I think yeah.
I can go first, yeah. So my name is Tracy Lane. I'm the ECMO program manager at Methodist Hospital with Indiana University Health in Indianapolis, Indiana. I've been in my role as the ECMO coordinator and then eventually a manager for the last 10 years since the program started. We're an adult-only program. And our partners Riley at Riley Hospital, their program has been around for a very long time. So a lot of people are familiar with IU Health, specifically for Riley's program. So we're very fortunate that we have them as a resource. And really through COVID and us seeing a pretty substantial spike in cases of ECMO, we've had a couple of our Riley specialists that have come to the adult world and started helping us over here as well. So that's been really helpful. Typically, we have between 80 to 90 cases a year of adult ECMO. We started out in 2011 and trained at University of Iowa with Elizabeth and Jen, as well as over at Michigan. We started out with only 10 patients that first year. So it certainly has grown, and operations have evolved over time as a result. And then we've seen so far this year 137 ECMO cases year to date. So we're definitely busy here, and I'm excited to learn from all of you what you're doing, and happy to share what we're doing as well.
Thanks, Tracy. Jen?
Hi, I'm Jen Crumley. I'm representing the University of Iowa. We are a neonate through adult program. Primarily, our growth is in the adult side of things. We average anywhere from 40 to 60 cases in totality per fiscal year. This year, we've definitely seen an increase. We're at 41 since July 1st, and we've roughly supported about 20 adult COVID patients, 2 of which have been pregnant while having COVID and on ECMO. So that was a new and surprising challenge. Our hospital is the only adult heart and lung transplant center for the state of Iowa, and the only pediatric heart transplant center. So we've really had to kind of work through some challenges of how do we allocate pumps to maintain all of those programs in the setting of COVID. Other challenges that we've kind of been forced to tackle is our staffing. We roughly have 32 trained ECMO specialists. Not all of them are working at the same time. So on average, we can support 2.5 patients 24/7 with very little issue, but that's not the current picture that we're facing with ECMO. So we've had to really try to incorporate alternative staffing methods. So pairing patients with ECMO specialists, moving patients out of ICUs into other ICUs so that we can co-locate. Some of it has been embraced and some hasn't. So, still trying to continue to work through all those challenges.
Thanks, Jen. I've neglected to add Erin August to one of our panelists, and just to announce her too. And Erin, while I'm at it, I don't know if you feel comfortable going next or not, but I apologize for that.
No worries, Christine, thank you. Hi, my name is Erin August. I'm an adult ECMO coordinator here in Hollywood, Florida at Memorial Regional Hospital. We were the first hospital to do ECMO transport here in South Florida. We had some challenges as well as a lot of the colleagues are talking about as far as COVID goes. An additional thing that we did, tagging on to what our other colleagues have shared, for us, what we tried to do when we were thinking about and thinking outside the box with COVID ECMO and what can we do, our hospital actually ended up being able to run ECMO outside the room. So when we were setting up and preparing and getting ready for this, as we knew it was coming, 2 days prior, our lead surgeon, Dr. Ewan Wong, challenged me with setting up his concept for running ECMO outside the room. So our hospital was so gracious as to let us drill holes in our ICU doors. They're the old wood doors, that we were able to run ECMO outside. So in addition to setting up, allocating enough that we could do COVID ECMO, allocating enough that we could run regular non-COVID ECMO, this was just one more piece we put into it as far as the equipment goes. Staffing wise, as some of our colleagues have discussed, we have 18 trained ECMO specialists. We're getting ready to, once we're allowed because of COVID, we're going to be doing another ECMO boot camp, training more specialists. We have RNs and RTs in our population, but also as we rise to the challenge, I've set a great deal of ECMO myself this year. So it's all hands on deck when it comes to staffing with ECMO, including myself. So I've been a VAD coordinator and worked as a bedside nurse taking care of devices, and now as an ECMO coordinator for a total of 25 years. This is my 3rd program I've built from the ground up, and the 3rd ECMO and critical care transport team I've made from the ground up.
Thanks, Erin. Appreciate that.
Thank you.
Mike, I think you were next in the...
My name is Mike Kotwas. I'm a perfusionist for a private practice perfusion group, but we cover a couple of big hospitals in Chicago. We actually cover about 10 hospitals in Chicago, and our 2 biggest and busiest are Advocate Christ and Rush University. We only do the adult side. There is a peds arm that specializes in the pediatrics, but this year was enough for just to take care of the adults. By the end of September, we had put over 82 people on ECMO with about an 85 to 90% success rate. And our challenges were creating a spoken hub, getting the equipment ready, finding equipment from all over the city, and just logistics of getting the patients to our 2 hospitals so we didn't have to separate and go to the other hospitals and monitor at those hospitals. So we're really happy that our physicians agreed with us with that game plan. When it first started, we actually talked about where we want to do it and how we want to do it. And it, so far, so good. It came into place. There's an occasional one where you put the person on at an outside hospital. You'll have to observe them or be with them overnight. 1 or 2 of our perfusionists will stay with them. And then they'll ship over either Christ or Rush. And that was really important for us. The other thing I want to say is we have 2 different types of programs where Christ is a perfusion run program and Rush is a perfusion for insertion, cannulation, change of circuits, troubleshooting, transportation, and they have some incredible ECMO specialists at Rush that are trained by Erica Bach and the rest of the team over there, which you know, it just really helps us out quite a bit too, because I don't think physically we could have handled it. We would have been working 24-hour shifts with, you know, just driving from hospital to hospital. So that's my story.
Thanks, Mike. Tammy?
There we go. Can you hear me?
Yep.
Excellent. So I'm Tammy Frederick, and I am a nurse at Mayo Clinic in Rochester, Minnesota. Our program actually started back in 2003, where there was 5 of us that became ECMO specialists from a perfusion run team. So they started training us up, and here I am a few years later doing ECMO. And through that time frame, I was the coordinator for about 5 years, and now dropped down to just a part-time position so that I can also be teaching in the ELSO world. But our program is pediatric through adults. And just like everybody else, we're now more heavy on the COVID side. Primarily, our program is VA ECMO, though, because we do so many bypass cases a year, right around 3,000. So that's really the nuts and the bolts for our ECMO program. We do anywhere from 80 on a light year to about 130 on a heavy year. This year, as of 2 days ago, we tapped 103 for the year so far. And our team consists of about 50% RTs, 50% nurses. We run with a team of 26. And as of January this year, we became a dedicated team. So prior to that, we used to be all sitting in our own worlds, and then we would be pulled back into ECMO as needed. And then as our numbers increased, our ECMO manager and our new ECMO director decided that a dedicated team would probably be best for us. And so now we are almost 12 months into this dedicated team, and it was probably a very good thing, hindsight, because as ECMO has blossomed, all of our patients live in our CVICU, both peds and adult. And then as COVID hit, we now have to pop off into our MICU to manage our COVID ECMO patients. So at one point, we were actually doing ECMO on 4 different units, which, as you can imagine, stretches our team very thin. And we can talk about all those challenges as we explain lots of other things, but that just kind of gives you the nuts and bolts of what's happening in Rochester.
Thanks, Tammy. Kelly, I'm not sure if Kelly is on. I don't know that I quite had confirmation from her. So Kelly, if you're on, speak up. I'll give it a couple of seconds here. Okay. Bernadette in the form of Phil. I think you're on mute.
I think he's still having bandwidth issues. He's been texting.
Okay. So Phil, maybe we'll come back to you in a minute or two. And Ethan Kurtzman.
My name is Ethan Kurtzman. I'm the MCS ECMO Program Coordinator for Hartford Hospital in Hartford, Connecticut, and Hartford Healthcare, which is about a 7-hospital program, 7-hospital system up here in Connecticut. We're adults only. We do about 70 to 75 cases a year. Our staffing model is perfusion for insertion, and then ECMO specialists for maintenance after that. So our ECMO specialists are respiratory therapists who go through a rigorous training program. We've got probably about 40 ECMO specialists right now, and we can have 6 people on support at a time here at Hartford. Our mobile rescue ECMO program is pretty robust here. We were the first mobile ECMO program, rescue ECMO program in New England. We do between 30 and 40 mobile cannulation and retrieval cases a year, and we get about 120 requests a year for mobile ECMO. We do, like I said, about 30 to 40 of those a year, and that's about it. Glad to be here.
All right. Thanks, Ethan. Phil, I'm going to come back to you and see if you're doing a little better with the technology aspects. Maybe not quite yet. Maybe.
I'll send him a text. Yeah, I think he's still having issues.
Okay. Well, I think it would be great to hear from everybody a little bit more in depth about staffing. And I know there's a lot of challenges with staffing, and especially as volume goes up and resources get a little constrained, but it would be great if our panelists could first share some of what you typically do with staffing, what you've been doing, or how you're approaching staffing now, and any either recommendations for everyone else or asks of everyone else for advice. So we could go in the same order for this one, if that makes sense, and then we'll shake up the order for the next couple questions. So Tracy, do you want to start us off on staffing?
Sure. Staffing is always such a tough topic. So, but starting with what is our ideal state and pre-COVID state will be an easy place to start. So, with our program, it hasn't always been this way, but really since 2016, we've had a dedicated team, what we call our core clinician staff. We call them clinicians in our institution versus specialists. So bear with me. If I say clinician, I'm referring to ECMO specialists. Our team are all RNs and RTs. We've had about a 50-50 split for a while. I would say this year, I just hired another group for the second time this year, and they're all nurses. So I think we are getting a little more like a 1/3 to 2/3 split with our RNs and RTs. But certainly, love the blend of both disciplines, and that works really well. Right now, we have 37 ECMO clinicians total, and 22 of those are core staff. And some of those are people who will spend 2 of their 3 shifts a week in ECMO and 1 shift a week in their ICU position as a bedside nurse or as an RT. So that shared role is actually a really nice way to build in, ways to what to do with your staff if your census were to drop. So we've had that going on for quite a while. We also have some people that are purely supplemental to our team, and that's also been great to deal with surges from that standpoint. So most of the time we have, 4 or 5 patients on ECMO at a time. The last probably 12 to 24 months, well, prior to COVID, I would say 12 to 15 months, we saw an average of 4 patients or more. Very rarely were we seeing our census drop below that. So that's been our basic staffing structure so far. We do have perfusionists that assist us when we have staffing shortages. So they will fill in with shifts to help us at bedside. But as far as initiations, component changes, circuit changes, things like that, we're a pretty freestanding program. But certainly we learned from our perfusionists back in 2011, and they're still very involved when it comes to equipment and ordering and things like that. We have a lot of support from them. So very grateful for our perfusion support as well. So with COVID, so it's how we staff, the ratios. We typically are a 1-to-1 or 1-to-2 clinician to patient ratio. And then our bedside nurse staffing, ideally we want it to be 1-to-1, but that has always been a challenge for us. So there are certainly pre-COVID, there were many shifts where you might have a nurse that had 2 patients, Maybe only one of them was on ECMO, the other one wasn't. But so in that case, we would try to staff one-to-one from a clinician perspective. If our bedside nurse is able to be singled one-to-one, then we would watch up to 2 circuits. So that's been our traditional staffing model. Now with COVID, we did, have a stated maximum for our program of 8 patients at a time, at one time. We are now at 12 for our max, but that number is, even as of today, going to start increasing based on equipment that we've been able to get from around the state, as well as rentals and trying to purchase and all of that. So we'll talk about equipment, I know, in a little bit. But certainly our staffing model has been challenged because our direction from our hospital is that we will take any patient that needs our care. We are opening up areas of our hospital right now that have been closed for many, many years, so that really all teams, even outside of ECMO, are stretched very, very thin with staffing. And we're kind of getting away from talking about staffing in terms of ratios because it feels very heavy to think of it that way. And instead, we're looking at more of the team approach. We're reducing documentation frequency and what we document. Certainly within, appropriate guidelines. We are reducing the frequency of circuit checks. We actually started doing that with COVID patients back in the spring when we started seeing those cases come in. And that was in an effort to reduce exposure to our staff, but more importantly, I think, was PPE as well. I'm trying to conserve PPE. So we went to every 2-hour circuit check with our ECMO circuits. And that has proven to be safe over the last 8 months that we've been doing this. So when we get into ratios of 1-3 or 1-4 with a clinician due to our COVID census and increased census, that we're going to that 2-hour circuit check frequency as well as reduced documentation and some other things. So that's really helped us sort of cover and, maximize surveillance. That's what I really talk to my team about, is we really want to maximize surveillance and decrease the taskiness. We don't want you in your computer. We don't want you burdened by tasks. What things can we do differently to manage all the things that we're being asked to do due to our patient demand? So that's just a little bit about staffing. I'm sure there's more things I can touch on, but that's a little bit about what we're doing here.
Thanks so much, Tracy. Jen, do you want to share what you're doing?
So I echo a lot of what Tracy has shared. Our program historically has always been a one-to-one staffing model program. Pre-COVID, we made multiple attempts to try to change that staffing paradigm to 1-2 at minimum. We've thrown the idea of a round of 1-3, but you have to crawl before you can run. Our ICUs are mostly set up in pods, with the exception of our NICU and PICU, which does make co-locating and pairing patients a little bit more challenging. Our children's hospital is actually set up in an oval type layout with all patient care rooms on the outside. So that does present a challenge when you're trying to pair an ECMO patient. But our adult ICUs have been very gracious and have allowed us to co-locate in pods so that we can have eyes on multiple patients, or at least have them very near each other. We will really only consider pairing our ECMO specialists if we can single bedside, just as another kind of safety layer for our ECMO program. Our team is comprised of nurses and RTs, same as Tracy's. We have a split of, we have core ECMO specialists, which are our primers, our initiators, kind of our shift supervisors. And then we have supplemental staff that come from all of our ICUs, including our respiratory therapists. So the challenge that comes with that is we are at the liberty of self-scheduling. So how staff schedule, we may have 15 ECMO specialists scheduled one day and 1 specialist scheduled the next day. So trying to navigate those challenges, COVID or pre-COVID, is always a good time. We, to help with pairing, and I can't take credit for this, but our ICUs actually started using baby monitors in the room. So they had baby monitors in the patient room, and then they had the controls out at the main nursing station so that you could hear alarms. We tried to adopt the less is more approach in terms of accessing the circuit, lab draws, kind of going over your circuit and documentation again to reduce PPE and exposure. And we really have tried to rely heavily more on our bedside nurses, in terms of if a patient's on CRT and the ECMO specialist is in another room with another ECMO and the CRT alarms, we've now said it's the nurse's responsibility to make sure that bed, is changed so that the patient isn't down off CRT for an extended period of time. It's a challenge when you have senior nurses and new nurses to the ECMO team. When I think you're more senior, you know enough to be dangerous. You've seen the bad things happen. And when you're new, you're kind of oblivious and you're just excited to be an ECMO specialist. And so it kind of comes with the good and the bad, and trying to kind of, recognize but yet calm the potential fears and ensure that you have safety layers for your team, and really trying to push your team, but also support them and encourage them that they have the skill set, they have the training that they need to, intervene when there's an emergency, and just trying to get them to trust in themselves and their skill set kind of seems to be an ongoing phenomenon that we continue to work through. In terms of COVID, like I mentioned, we've had 20 overall. We did have the challenge of having 2 patients that were pregnant at different stages in their pregnancy. Happy to report that we have had 2 healthy COVID ECMO babies born and are home with moms. So that's exciting and good news in times when I think we could all use something like that. We have roughly, like I said, 32 staff, 7 core specialists. We continue to onboard about twice a year. Our turnover is fairly frequent. We lose a lot of staff to traveling, to CRNA school, nurse practitioner school. So trying to maintain a senior level of staff can be somewhat challenging and make things a little more difficult for us from a coordinator perspective. But yeah, that's kind of us in a nutshell.
Thanks, Jen. That's a great overview. Mike?
Because we have 2 different programs, our ECMO specialists, our ratio is usually 1 to 3, and that's where they want to keep it. And we have a nice design of an ICU where it's kind of like a V shape. So if one is getting a little overwhelmed, the others could help. At Christ, though, where we had our most, and it's perfusion run, our usual ratio was 1 perfusionist in-house with all the ECMO, because we had 1 unit, and we could do up to 10 patients with that. During our peak, when we had around 40 people on, we had 4 people during the day, 4 perfusionists during the day, and 3 on at night. During the day, we had the extra person because a lot of excursions happen with these patients, either going to CAT scan, IR, surgery, any number of places we could, take them for trips. And we could even take them outside if we wanted to. That was our model. Our peak at Christ was about 35 patients or so at the same time, and we converted 1 20-bed ICU. We doubled beds and had 25 in at one time in that unit. And then we had a separate unit for the non-COVID ECMOs that we still do. VA, VVs, and emergency hearts had to go to another unit. So our entire surgical heart unit was converted to COVID. And we had a lot of challenges because we had a lot of nurses from outside hospitals that came and helped. They were paying good money and they wanted to be part of this situation. And thank God for them because they were incredible. But we were doing a lot of education during the day. These nurses would were never exposed to per se VV ECMO, let alone the numbers that they were seeing. We tried to have the nurses as a one-to-one, but we also had the ones that were very new and very green. We would sit and spend extra time with them, teaching them. It's a big challenge understanding blood gases on VV ECMO versus VA ECMO, and just understanding blood gases on these ECMO patients. And we were really proud that we were able to educate these nurses, which I think were really important. And the physicians were also there for education. We have some incredible RTs that were there also learning about it, because it's something total out of the ordinary. If you don't do enough of them, it's like speaking a different language. So that was probably one of our initial challenges with the volumes that we had. You know, initially our physician said, be prepared for 50 ECMO patients just at Christ. And when that happened, you know, bottles were popping. We were starting to drink, figuring out how we're going to do it. And we got a plan together. We talked with the physicians, anesthesia, RTs, everybody. We had 2 different protocols for both different hospitals. But I think we can be proud of where we came so far. We have a lot of people home now alive because of that. So.
Yeah, that's great. Thanks so much, Mike.
Sure.
Tammy?
So as I said, our program started with perfusion and then rolled into this ECMO specialist platform, RN and RT. Our perfusion is deeply vetted into our ECMO program. So they are part of all patients that go on ECMO. They assist with all transports intra-hospital and outside of the hospital. So they're still really vetted in our program. They round every day. They help, you know, assist with any way, shape, and form short of staffing, because they really belong in the OR when we're doing lots of cases. So as we moved to this COVID platform where our patients were up in an ICU above where we normally staff our patients, we had to be a little bit more creative. And so we started staffing them 1-to-1. And, you know, we have glass doors on all of our ICU rooms, so we could still visualize the ECMO pump. And our ECMO specialists only do circuit assessments Q4. So just like the nursing world, we just do them on like the 8, the noon, and the 1600 around the clock. Our ECMO specialists are also involved in ordering all the labs, managing all the labs. So when they come back, we, you know, alert the nurses and the doctors if we have things that are out of whack, and, you know, we manipulate the pump accordingly. So they kind of practice a little bit higher up there. You know, we're making sure that they're staying very involved in all that as well. And then, so our minimal staffing on an COVID ECMO unit is we have 2 patients, we run with 2 ECMO specialists, because we don't want to have 1 ECMO specialist up there all by themselves. So if they're in one room and they can't hear a pump in another room, that's really very unsafe. So then as we start to get to 3, then we'll go to 2. Currently, we have about 7 ECMO specialists per shift, Monday through Friday. It drops down to 4 days, 4 nights on the weekends. So when you look at your staffing model, it's like, how can you take those 7 people and best utilize them? So perhaps, you know, our more seasoned ECMO specialists could be taking 3 pumps. We've never had to go to 4, but we've had gone to 3 a couple of times. And then you're just all kind of helping each other out, kind of like I think everybody has said here, you just all pitch in and do it really well. We've built in this contingency plan should our numbers get to a point where it's just unmanageable with 7, that then as ECMO specialists, we'd be required to pick up 1 call shift per pay period. We haven't had to go there yet. I think our peak numbers for pumps running for this year, I think was like 9 or 10. But because our CV surgery numbers have been so slow, it's kind of alleviated that stressor on us right now, and where the VV has kind of peaked and taken over some of our ECMO team. So we've been very fortunate in that realm. Our bedside providers are RNs and our MICU RNs, and now they're being trained to manage these ECMO pumps as well with the ECMO specialists, because before it was always our CV ICU nurses. And so that's been a little bit of a challenge, trying to train them up and like Mike says, kind of let them know what's normal for a blood gas, what's normal for a SAT. But all of our nurses are 1-to-1 with our ECMO. So we are very, very fortunate, as I listen to all of you guys, that we always will have a bedside nurse at the bedside 24/7.
Thank you so much, Tammy. Phil, I'm going to go to you next. And if you could introduce yourself and a little bit about your program, and then talk about staffing.
Yeah, hey, thanks, Christine. Thank you for your patience with my technical difficulties. So my name is Phil Mason. I'm the ECMO Medical Director at Brooke Army Medical Center in San Antonio, Texas. And though we are a military hospital, we treat the majority of our patients, we treat our civilians. So that's where we get our numbers from. Our program's been active for about 8 years now, but built on a 25-year history of a neonatal and peds program. Currently, our volume for this year is going to be about 60 patients, and about 40 of those will be transports from outside of our hospital. So the majority of our cases, we cannulate externally and then transport them in to keep our program busy. We are a standalone program. There's almost no perfusion involvement in the program, which I think is fairly unusual. They're very helpful. The relationship is cordial. They just do their thing in the OR. And I have 2 very, very experienced, highly capable RN ECMO coordinators. that have trained up a small cadre of primers, and then they really fill that niche. So all the initiation, circuit changes, troubleshooting, and oversight of the ECMO specialists. And they're all RNs, as are our ECMO specialists. We've had a handful of RTs over the years, but generally we're exclusively an RN ECMO specialist program. And I think whatever, different hospitals have different ways to reach success. In our personnel model, that's what worked best for us. So that's what we've done. Our bedside nurses, ICU nurses that take care of all the patient's needs, are 1-to-1. And that's pretty reliable. Even during COVID times, a few times they've gone to 2 patients, but generally that's a 1-to-1 job. Our ECMO specialists, it's been fascinating, actually. I was trying for a long time to find some more efficiencies in our program. And some of the nurse ECMO specialists on here may cringe, but we had for a couple of years now been a 1 ECMO specialist to 2 ECMO patients, so a 1-to-2 program. And I really felt like we needed to get to 1-to-3 and then 1-to-4 in order to really find efficiency and grow the program. And really, I found the most important things to do to accomplish that were, look at what your ECMO specialists are doing. If they're doing something that is either wasting their time and is unnecessary, or something that the bedside nurse should be doing, they need to stop doing it. And so we had already adjusted our documentation. We had gone to every 2 to 4 hours now. And that was right before COVID, and it was timely because it facilitated some changes. The truth is, I'm an ECMO physician, and I look at the flow sheet a lot. And I've never wondered what the RPMs were every hour for 24 hours a day for 7, 14, or 90 days on ECMO. It just doesn't make sense. And so that was a big change we made, was documentation. And that really was kind of evolving as COVID came along, and COVID nicely accelerated that for us. The other thing is our ECMO specialists, really, they're all ICU nurses, as their background. And probably like many of you, they're our strongest ICU nurses. They're very high performers. They're very experienced. So when they stand at the bedside and the patient needs to have a new drip started or titrated, or the patient needs a blood product transfused, or the CRRT is alarming, the ECMO specialists were taking on all of those tasks. And so I had to repeatedly ask all of them, what if this patient wasn't on ECMO? Who would manage the CRRT? And the answer was the 1-to-1 bedside nurse. And so I really focused on pushing that bedside nursing workload back to the bedside nurse. Remember, they're 1-to-1. And just because my ECMO specialists are the highest performing nurses in the hospital doesn't mean they can take on every task. And so by pushing that workload back to the bedside nurse and adjusting documentation, we very quickly adapted our ratio to 1-to-3. So 1 ECMO specialist to 3 pumps right as COVID came along. And that really expanded our volume up to 9 simultaneous patients, which is very helpful. I would say the other thing we did that really facilitated that change in staffing and efficiency was at our peak numbers, we adopted an open PACU. Our PACU was closed, one of our PACUs, because elective surgeries were closed down. And that's a nice open bay. So I can stand in the middle of the room and reach out and touch all 9 of my patients. And so that was a very helpful change, was opening that as our ECMO unit, where all 9 patients were in the same room. It's exhausting for the staff because they're in PPE, for several hours at a time until they leave to take a break. So there was a downside, but from a communication and being able to monitor multiple complicated patients, that was a very helpful change that we made that facilitated an adjustment in staffing ratio. My focus now is on holding these gains once COVID finally dies down. When we go back to our normal operations, I want to make sure that we maintain these staffing changes because they've been safe, they've been effective, and I want to make sure that we don't lose that ground.
Thanks so much, Phil. Great overview. Ethan, and then Erin, and then we'll open it up to anybody else on the call if you have questions or something you want to share. Go ahead, Ethan.
Sure. So, from a staffing perspective, we're doing okay here. We've put a lot of our respiratory therapists through the ECMO specialist program. And, based on the volume that we allow, being at 6 cases on at a time at most, staffing wise, we're in a good spot. We will allow for the specialists to go to a 1-to-3 ratio. Typically it doesn't happen because we've got enough specialists on a shift that they, can each take 1, and it's not generally an issue. What was nice about COVID was as our CT surgery volume dropped, perfusion became more available. So, the whole point of the ECMO specialist program for us was really to alleviate some of the burden that was on the perfusion team. As their OR volume dropped, we were able to utilize them a little bit more and let the ECMO specialists, if needed, shift back to doing, regular respiratory therapy duties, because that was, obviously the burden on the system was the respiratory end of things. But really, staffing wasn't an issue so much for us as it was bed capacity. You know, we had during the pandemic, even during the peak of the pandemic, we had the ECMO specialist staffing and the perfusion staffing to maintain 6 people on at a time if we needed to. What we didn't have was beds. You know, they were trying obviously to preferentiate COVID patients to our MICU. The MICU was full, so we were kind of making up ICUs or wherever we could find space in the hospital. And every single one of those beds was filled with a patient on a ventilator with COVID-19. So, you know, that was the issue, was just having a place to put these patients. And where we felt that probably the worst was having to say no to all of these mobile rescue ECMO missions that we were getting. You know, in the peak of COVID, we would get 5 requests a day to go put someone on ECMO at a community hospital and bring them back. And many of these patients met clinical criteria, but we found ourselves saying no for resource issues. And then, you know, we can talk later in this discussion about, you know, using resources in the community, in the region, as far as bringing these patients elsewhere. But, you know, what we felt really was getting these simultaneous requests for mobile ECMO missions, triaging who we're going to go take care of first. Do we have the capacity to go take care of the second phone call? And then on that note, the burden on our transfer center from the staffing perspective that, you know, we have a dedicated ECMO line and that phone was ringing off the hook every day, and it put a burden on our you know, care logistics center. So again, you know, we have the staffing, we've trained up a ton of ECMO specialists. They're eager, they're ready to work. But, you know, in the peak of all of this, it was just a matter of we have no place to put these patients. So that's something we're working on now. We're coming up with better plans. We're trying to dedicate, you know, more space. Historically, we only had ECMO patients either in our CCICU or CICU or cardiac ICU, and now we've opened that up to our MICU. You know, we have a relatively straightforward VV case, maybe go to our MICU because the ECMO specialist, the RTs, their ECMO specialist can work anywhere in the building. So we're working on it, but that was our goal, was just having a bed to put everybody in.
Great. You got a little quiet there at the end, Ethan, but I think you were saying that you've talk a little bit more about where your patients have typically been and what you're doing now with space.
Yeah, so historically, all of our ECMO patients would either be in the CT-ICU or cardiac ICU. We've got a lot of ICUs here. And as we found that, you know, now that our CT surgical volume is picking up, there's less beds in the CT-ICU, and we want to alleviate the burden on those 2 units. So now we're, you know, exploring the options of putting a stable VV case in the MICU because, you know, while the MICU is not as comfortable with these ECMO cases, the ECMO specialists that are respiratory therapists cover the entire hospital. So they're comfortable managing these patients anywhere in the building. So that's helped us out.
That's great. Thanks so much, Ethan. Erin?
Okay, so thank you. So I'm Erin August. So for our staffing here at Memorial Regional Hollywood, so our program is 5 years young. We've been steadily growing at a really ready pace, and we have 18 specialists. So what we do is our specialists sit no more than 2 pumps at a time. Our perfusionists and myself can sit up to 4 pumps at a time when need be. We can staff anywhere between 6 and a high of 8 ECMOs at a time. For COVID, we've been split. Typically, all of ours are in the CVICU as well. However, with COVID, we had units that were just, you know, only 4 COVID patients. So we were allotted a total of 4 and then up to 6 beds that we could go ahead and drill the holes in the doors in order to run the ECMO outside the room. We also had to work on the circuitry in the unit because it was an older unit in order to supply enough power for everything, especially for the cardio clips. The cardio clips, the heater coolers, they tended to draw more amps than what that unit was used to having. So our internal engineering did a great job at running extra wiring to allow us to be able to support something in one of the older areas of the hospital. So that was helpful. For us too, our ECMO specialists are multifaceted. So they are our CVICU high performers who have gone on for training to become ECMO specialists. Now in the pandemic, it's been a bit of a challenge because again, we're pulled all over the place. So typically what we've done in cases in order to make sure there was enough staffing to do everything is that looking at the staffing for the day, we'd look the night before. If the nurses needed to be pulled back in order to do patient care, the ECMO specialist RNs were assigned to the ECMO patients as the ECMO nurse. And then either Perfusion or myself would go ahead and sit the pumps. So that way we could still make sure that we had enough ECMO, per se ECMO knowledge staff in order to take care of those patients during this time. ECMO specialists are also our transport team. So anytime we had that, so it was kind of like playing chess all the time, each and every day. So we meet and we constantly look at things, evaluate things, see who can be called in, see who can be pulled around. We're working on an ECMO specialist call schedule going forward. That was one of the big takeaways from COVID. And also we assign an ECMO specialist every day. So even if we didn't have somebody on, we had someone that we could quickly pull if we got called in order to put somebody on. So that way we could take our mobile ECMO. We have a circuit that's primed and good for 60 days. We always keep. We have an ECMO cart that we can take with us with all the supplies on it anywhere in the hospital that we need to. And then we also have our mobile supplies. So we're ready to go anytime. So we could quickly readjust staffing in order to handle the needs. So having it like this has kept the schematic, really nice and easy, considering the challenges that we've all faced. So we can pull and act quickly to help the patients.
Thanks so much, Erin.
Thank you.
Is there anyone on the call that wants to offer something about how you do staffing or ask a question or share a concern about staffing? There's been some really good comments coming in and through the chat as well about staffing and also running the equipment outside of the room. That was a really brilliant idea, Erin, that you and your team had.
I think Amy on here poses a great question that I know I hear a lot in the comments. So Dr. Hackman wrote, is there any tips on making everyone more comfortable when you begin increasing specialist staffing ratios? She's heard a lot about anxieties, people not feeling comfortable, raising patient safety issues. I'm curious from our group of panelists, Mike, I'll put you on the spot because I think you win the award for your team rising to the occasion and covering a huge surge. So any tips or tricks that you had, especially since I heard you were doing a lot of like just-in-time training with the nursing ICU staff. So any pearls of wisdom of how to get people comfortable?
Well, the nice thing is our physicians picked one way of cannulation because we think it's the best way, and it's the Protect Duo. And our pumps are identical. We have centromags everywhere. So if we were intercepting a patient from another institution, we would have them on a centromag because we were able to get as many as we needed. We even told other hospitals, we're welcome to take your patients as long as we get to keep your equipment for at least 24 hours. And then we would switch them over to our circuit. So it really made it nice where everyone had the same piece of equipment, same cannulation. Another nice thing that we did, and it was a stress reliever for a lot of the staff, is we de-isolate them. And post ECMO insertion on day 6, they would do a test. And if the test was negative, they would do another one on day 7. And if both were negative, we would de-isolate. So then you could have all the equipment back in the room. You could have the doors open. Your PPE is not as intense, I would say. You could see the patient right there. It's a lot easier going from one to the other. When we had the peak or 2 patients and all, we would write on with wax pens on the door. And we would also because we like using Seroquel to keep people calm, we put their EKG of the day up there. So if we part of our rounds 3 times a day is looking at all that stuff. So helping these nurses, you try to pair them up with an experienced ICU nurse from Christ or Rush, and then you put these other patients, the other nurses in where they could see the less intense patients, the patients that are already extubated. So they have a lot less stress about managing ventilator, CRRT, and we just took the time. We held their hands. We did a lot of education, and I would bring around the cannula and show everyone what the cannula looks like. Then we would look at the chest X-ray, and we could actually see where the cannula is. So we kind of, did a little on-site training that way.
No problem.
And I think just education is the best thing for everybody. I think the nurses love it. I think the respiratory therapists love it. Even some physicians that were coming around that were really like wanted to see the disaster, they came down and we educated them on what ECMO does.
Oh, great point. I applaud the efforts, because I think what we hear frequently, right, is that, in crisis, that's the last time you want to be completely changing paradigms, right? But at the same time, a lot of us were faced with the reality that for every time you couldn't push yourself to think outside the box, that means you were telling someone no, and you were limiting what you could offer. And I think that's, those moments went out of which one are you going to choose, and put a lot of moral stress on teams to figure it out, but then have to deal with the aftermath of, we're asking people to do things that make them feel uncomfortable. And so how do you support those needs?
We were really stressed out about oxygenators at the beginning.
Hey, Liz.
We called all the hospitals in Chicago that do ECMO, and we had a text chain going together. How's your numbers? What do you have? And Northwestern gave us a couple oxygenators. University of Chicago had some expiring within 2 months, and we would use that in 7 days. So, I mean, we kept communications in our region as intense as we did communicating with each other and with the nurses, because I think you have to know what's out there, what's available for you immediately, because you could go to any of these hospitals. There was no traffic. It was really nice in the city. You could get from one hospital to the other within 30 minutes. And, or you could even have an ambulance or Uber driver drive something over to you if you needed. But I think one of the things is having that comfort knowing that the equipment is there if you need it, especially when you're expecting a surge. Every hospital that we went to in our Spoken hub, like I said, has Centromags, and we make sure that was, they have 2. So when they put one in, they could still keep one there. So if we had a place that had a second person that needed to go on, they had another Centromag. Abbott was really helpful with getting us loaners. They still are helpful getting us loaners. Their heads are very expensive, but I mean, just because it's so easy to transport and all, I think it's worth the price of that. Same thing with the Protect Duo. That single cannula, I know every one of our surgeons said that was their idea, but I remember the first patient we put on, and I knew I didn't want to go into that room every few minutes. So Protect Tool, we unload the right side. We had no mixing, and we could sit outside and look at our SVO2 and know it's not going to be a mixing SVO2. So pressure makes diamonds, and we had a lot of thinking to do in a quick amount of time just to keep things going the way they are, and so far so good.
No, that's great. What I heard from that was a standardization. So really being intentional on design and how you standardize care, a lot of education and reassurances, and thinking through what the concerns would be ahead of time and trying to head those off with communication points. And I think Dr. Mason, who's switching around on my screen, I think I heard his voice and now he seems to disappear. Phil, did you want to add some comments in there? And I think he may have officially jumped off.
Liz, I'd like to kind of piggyback onto what Mike had to say. We historically were always like the 1-to-1, and then when we broke out into this COVID and we were doing more 1-to-2, and our manager said, I think we may have to go to 1-to-3 if we put this other patient on. Mike really hit the nail on the head. It's all about just supporting your team, finding out really what is their stressor. Is there stressor that they can't get in the room and assess it every 4 hours? Is there stressor that they don't feel that their PPE? I mean, I think there's some hidden undertones under some of the stressors of these ECMO specialists. And it's probably not because they can't do it, because they're all highly trained, they're super smart people. It's just like, what is those minor things that they may be just really fighting within their brain? And so really, as an ECMO specialist, I'd reach out to my partner who was maybe up in the COVID world and say, what are your concerns? What can I do for you today? How can I help you? Do you want to go for an extra walk? Do you want to take an extra break? Really supporting each other, because if you burn out each other quickly, we're in this pandemic for how many months, it's going to be horrible. And yes, it's bedside teaching. It's teaching that nurse the same thing day after day after day, but then they have to feel comfortable about being in that room by themselves.
Tammy, I'll tag on to you too. I agree, because I think that's another thing we as coordinators can do for our staff, to give them that ability to walk away, take a breath, take a breather. I mean, because we know how hot do you get wearing all that PPE and when you go in there and things like that, you know, to give them that break, but also be their resource. You know, something is going on with the patient, because we know these COVID patients, ECMO patients can turn on a dime anyway. But these COVID patients, especially, so when we were trying to figure out the anticoagulation and everything else, you know, they were really afraid with things like that. So to know that you're right there. We also did daily rounding on them. I would round on them, you know, a couple times a day. And I'd say, okay, also call me. I'm like, if you're stressing out, if you're not sure about something, you know, I made sure I was there for them. And as did our perfusion. Our chief of perfusion and I have worked steadily together to support, you know, the whole team, whether it be perfusion. I would go down and break perfusion. They, you know, everybody needs a break from this type of thing, and just to come up for air, because we know how hard it is too, being in those N95s and respirators all the time too. I mean, one of the biggest complaints we'd get too is that, you know, they would get headaches and things like that. So all those things mean a lot as far as support goes.
I just want to piggyback too. I think one of the triggers that for my team is, and you know, we talked about this the other day a little bit about, you know, the season, more tenured or seasoned ECMO specialists tend to have the hardest time with adapting and changing and expanding, you know, the ratio and watching more patients. But I think the root of the anxiety the most common root of the anxiety, I think, is having patients on ECMO that don't have eyes and ears on them for a period of time. And that is a consequence, I think, of having bedside nurses not be one-on-one, having ECMO specialists not be one-on-one. You know, you might have your nurse and your clinician in the room turning this patient, and these other patients out here don't have anyone watching them potentially. So I think that it's that, you know, tether that you feel to that circuit, right? To watch the circuit to make sure nothing's going to happen to it. And you know, it takes seconds for air or, you know, blood to exit the circuit or entrain into the circuit. So I think that's what concerns people the most is making sure that they can be right there if there is a circuit emergency. And the more thin we are all spread, you know, I mean, I've walked on the unit and I've seen patients where there's not a nurse or a clinician, you know, keeping an eye because they're with another patient. I think that, I don't know if I'd love to know from the rest of you how you manage that, or if that is a concern. And maybe that's just old practice, that ECMO standardization is kind of, you know, you hear Dr. Bartlett say, kick it under the bed and forget it. I mean, you know, I don't know. So what is the thought on that?
I think Dr. Mason, you were finally able to join us back in. So I know you had some comments on that.
Yeah, I think there's some sunspots down here in San Antonio that are interrupting my connection. So it's actually great what you just said, what Tracy said, and I'll kind of follow up, because I feel like there's still a fair number of people in the adult ECMO world that grew up doing neonatal and pediatric ECMO with roller pumps. And those devices and those patients absolutely unequivocally require somebody handcuffed to that machine 24 hours a day. And so as the equipment has become a little simpler and has some inherent safety to it with centrifugal pumps, I feel like a lot of it is just fear of the unknown and habitual staffing. Now, I'm not here trying to encourage you to be cavalier about how you staff ECMO, but I would at least challenge the norms and challenge those perceptions about what's really required versus what have we always done. Another question I would ask, and I ask commonly in my program, is what is unstable? And when I'm told we staff this way because the patients are unstable, it kind of comes back to something I said earlier. Unstable might mean a lot of pressors. Unstable might mean busy with transfusions. Unstable might mean high ventilator settings. Well, all of those problems are solved by the bedside nurse and the RTs when the patient's not on ECMO. It's unusual that the ECMO pump is, quote, unstable. Now, sometimes it does. I understand that there's issues and at times, but generally speaking, an unstable patient for me, you have to break down what's unstable about this person. Is it ECMO related, or is it just a really sick patient? Because if it's just a really sick patient, then I think it's helpful to, again, try to push that back to the bedside nurse. A few things we've done to help with the comfort level of people. Somebody mentioned a minute ago, just the fear of not having eyes on the patients. Obviously, that's a problem. We've enlisted some medics that we have in our ICU that are generally underutilized. They're not qualified to operate the ECMO pump, and we haven't sought to do that. But they are qualified to keep eyes on an ICU patient. or they're qualified to go run to the Pyxis or run to the supply room or do other things so that the nursing staff and the ECMO staff can stay at the bedside. So we've used them as extenders really in the things that they're qualified to do to free up the ECMO specialist and the nurse. And then I'd say the last thing we do is, fortunately or unfortunately, I have a lot of ECMO specialists trained in my program. So it means a lot of them are pretty green and they may not get as much experience and expertise as I want. But it also means that a lot of times my bedside nurse happens to be an ECMO specialist, on a different day of the week. And so there is some extra ECMO knowledge, so to speak, around the ICU. And that helps you. Again, even if they're not functioning in the ECMO specialist role, the ECMO specialist is comfortable taking a few more pumps if they know that there's just a general critical mass of ECMO expertise there in the ICU, which is just something that we're fortunate to have here. So that's kind of my thoughts on it, but it's tough. But I think the other thing is you just have to realize if we keep doing things the way we've always done, then we will never move forward. Nobody's going to show up in your ICU tomorrow from administration and say, here, I just brought you a dozen brand new nurses, have at it. Why don't you put them on the ECMO pumps? That's not going to happen. And the way ECMO utilization is increasing, we have to find efficiencies or we're not going to be able to keep up.
I think the one thing that I would add to everything that everybody said, I 100% agree with, is I usually try to share with my staff, I started ECMO 11 years ago, and I still remember to this day the first time my medical director asked me to wake a VV ECMO patient up and then wanted me to sit them up and stand them. And I literally told him I thought he was crazy. Like, why would you want to do this? And now here at Iowa, that's our standard of care. We consider it to be a failure if we cannot wake our patients up and potentially try to extubate or, walk all of our VV ECMO patients. So, I mean, I know the gut wrenching feeling, the ulcer inducing panic that you can have of going through everything that could go wrong. But when you break down your data and when you look at your program, most all of your emergencies are something that we did as a specialist because we were getting access to the circuit or, but that's why we do emergency drills. That's why you have competencies, to err is human. So, there's always going to be that what if, but you cannot be held hostage by the what if. So you gotta, if you don't think outside your box, you're never going to grow. So.
Can I also ask Mike to talk a little bit about PT and ambulating ECMO patients? I know you've had some great experience there too, and that question has just come up in the chat.
Yeah, so within 7 to 10 days, we try to get the patient on a Craig bed. We also try to extubate them within 7 to 10 days. Some of these people have been prone for more than 7 days. So usually the first 5 to 7 days, you're detoxing them. There's so much on the way of medication that they're not alert, awake anymore. They're literally drugged up. So we work very hard on getting them extubated. We notice 7 to 10 days, all of a sudden they'll have a whiteout chest x-ray. That's okay, we expect it now. We still work on them to be alert enough where they're having a cough or a gag. We'll extubate them. The Craig bed helps us reposition them. We want their gut working, so we avoid benzos. And then we'll have them foot dangling after a few days in the Craig bed. Then we'll have them sitting up and then just going to the chair. And it's really nice with the Protect because it's wrapped and secured around their head that you don't worry about the legs. Even though we do mobilized VAs as well, which can be FemFem or FemIJ. But we get them up moving and then we walk them around just in the room. And we have full staff for it. We have ECMO specialists, we have physical therapy there, and then we have our respiratory or perfusionist around and the nurse too, the bedside nurse also helps us. So it's a team approach and we don't push them. We do push a little bit, we want them to get up. We want them in the morning. We want everyone to be sitting in a chair. We want them to be partaking in their recovery. We want to rehab them while they're on ECMO because their lungs aren't doing much. This is a lung problem. This is not a cardiac problem. This is not, injury. This is a lung problem. And we could certainly rehab them to the point where we discharge them home from the ICU. We might put them in an LTAC for just a couple of days, but we really work hard on rehabbing while on ECMO. And it's huge. We had one gentleman that was on for 95 days, rehabbed. We sent him for another institution that will do lung transplants. He got a lung 5 days later. He's walking around, never had a trach. We don't trach anybody. We really work on extubating them. And I think that really does help with the mobilization. You're not getting aerosolization as much, we find. And usually they're negative by that time. So if we need to, we could put a mask on them as we're walking them out in the hallway. So that's how our rehab works. And I'll tell you, the physical therapy people are incredible, just incredible.
And can you remind the group what your outcomes have been with that model? And just
well, recently we've had some really tragic patients that were really sick. So we probably trached about 7 people, and our total numbers are a little over 100 patients on ECMO already at both institutions. We actually might have an 8th trach. And these people are, you know, their lungs are, you know, when we saw the transplanted set of lungs, they look like beat up pieces of ground beef. And these people are bed plugs. They're going to take a while for they could come off of ECMO. So it's going to be a long haul, but we're committed to them. We really want them to get better. We want their lungs to heal if possible. If not, we'll try to get them a Continental Lung Transplant Center.
I think you had mentioned earlier, you had about an 80% survival rate though for your VV ECMO, your COVID-19 patients.
Yeah, absolutely. That's currently our numbers. We did a paper on our first 40 and everyone survived. And now we have another paper coming out with our next 40. And they put an endpoint for some of our first 40 ones also. So, you know, it's still a learning process for everyone. You know, the narcotics, all that stuff. I mean, everyone wants them sedated and all because they want to deal with the saturations. I think a lot of times the staff need the medication and not the patient. You could have them tachypnic breathing 40 times a minute, and you ask them, "Are you doing okay?" And we say, "Yeah." We had one guy who was just frothing from his mouth, and his lungs weren't contributing, but he was extubated. And he could sit there and play video games, and he's breathing 40 times a second. His heart rate is fine, everything is fine. And you just say, "Are you uncomfortable?" And he'll shake his head, no, he just plays video games. So it's a lot of learning, a lot of being patient with your staff, with yourself, and the confidence that you know you could do it, you know.
Thanks, Mike. I know we've got about, 20 minutes left, and I know ECMO equipment, if any of you are struggling with that or how you're managing that is one thing, but that might marry nicely with the topic of any efforts to collaborate or cooperate on a regional level. So I thought I might reverse order for this. So we'll kind of combine those last couple of topics just to make sure we have a chance to share what we're learning. And if this is of interest, we can do this again and get more time, you know, with people, hopefully. Well, I won't speculate on what the numbers are going to do, but why don't we start in that case then with Erin, if you want to talk a little bit about any efforts that you've done for regional collaboration or cooperation, but also as it relates to ECMO equipment, if you've struggled with that and how you're working to try to maintain enough supplies.
Sure. So we were lucky whenever we knew this was coming, the hospital allowed me to buy extra disposable supplies because as we know, COVID, especially being so bad, and then we knew it was going to happen going into flu season. Everybody knows the word allocation, right? As far as disposables go. So we were trying to plan ahead. We also invested and bought the Euroset AMG on top of as many Quadrox Ds we could get a hold of. So once we stockpiled with everything like that, we went and we counted up and we started our little schematic of how many patients did we think staff-wise we'd be able to support to make sure we had enough equipment. From there, we also started planning for the bigger picture as to what capital requests we would put in emergently versus going forward so we can continue to build our arsenal of things. it's always good to know, and we did have a regional group between ourselves, Cleveland Clinic in Weston, JFK, you know, and other areas in other hospitals in our area that we knew had the ability to do ECMO. We quickly collaborated with them too to say, okay, what is your platform? What machines do you use? What disposables do you use? So we could quickly get together and say, okay, this is what we have. So we could support each other. Bed wise, you know, management wise, equipment wise, disposables, things like that, especially with us being in South Florida, being in a hot spot like we were. So we wanted to make sure everybody had enough of everything. That worked well. You know, we were able to go ahead and share that cup of sugar with our neighbor when they needed something. And then when their order finally came back in, they'd quickly return it back. So that way we were being good Samaritans to one another too, and making sure what we borrow, we gave back, because who knows when you might need to borrow again. So it was just one big collaboration of making sure everybody had everything in order to, you know, make sure everybody was okay. Because I know at one point there was a little bit of a scare too, because Abbott told us, you know, we're really running low on rentals. So that was another thing. And I know Abbott has told us since then they've made sure that they have enough to support the ECMO community, because so many people were moving towards CentraMag because it is a nurse-friendly device, because most hospitals that do any kind of rescue device have CentraMag to do LVAD, RVAD, BiVAD. Well, and then you put the oxygenator in and there you go, you have ECMO. So, you know, it was a huge undertaking for them too, and a learning curve for them to make sure that they have enough to provide to us.
Oh, that's great. Thanks very much. Ethan, do you want to share what's happening at the Hartford, your neck of the woods?
Sure. So the Northeast is a really close group of people, you know, New York and New England, and everyone kind of knows everybody around here. So when things really started to pick up back, even before things got really bad, you know, end of March, beginning of April, you know, we kind of anticipated that these surges were going to happen. And as the phone started ringing for all these, you know, COVID patients to go on to support, we reached out to our colleagues in Boston and New York, in Maine, New Hampshire, Vermont, everywhere. And we kind of put feelers out for what was going on with everybody else. And we decided, kind of not haphazardly, but informally, we wanted to sort of create our own little group. So we, in about 25 minutes, we unofficially put together the Northeast ECMO Consortium, which was all the ECMO centers in New England, plus most of the ECMO centers in New York City, and the greater New York City area. And we just started having weekly Zoom meetings. And we talked about what was going on in each region of the Northeast. We talked about what our volumes were like. And then we actually just created a website, and we started sharing equipment. So how much equipment each facility had, what equipment we were using. And that gave us the opportunity to share as things needed to happen. And it went greater than just ECMO. We started talking about what CVVH equipment we were using, if that was available for sharing as well. And then probably the most remarkable thing that it all did was we created this mutual aid network in the Northeast. And when one center couldn't take a mobile patient, we knew who could. So we could look at the spreadsheet and say, we don't have a bed here, but Tufts is saying that they have a bed. And we'd reach out to Tufts and say, can you take this patient? And we would move the patient there. And we did that 3 or 4 times, where we would get a mobile ECMO request in Connecticut, and Hartford couldn't support the patient. So our mobile team would go out, put the patient on support, and we'd fly the patient to Boston and bring him to a hospital up there. So the regional approach that we used with the NEEC was really remarkable for just studying the trends, you know, in the greater Northeast area, seeing what the volumes were like, seeing what our outcomes were. You know, as things slowed down, we're doing monthly meetings now, but we stay in touch. Right now, we're working together to get IRB approval to create our own registry to start sharing data and doing some research. So, you know, any opportunity you have to utilize your colleagues around you, you know, there's power in numbers, and it's always great to share information with your colleagues and help out as much as you can that way. So that's sort of the regional approach that we've taken up here in the Northeast, and it's really worked out beautifully, and we're happy to have ELSO support for that.
Thanks, Ethan. Phil?
Hey, thanks, Christine. So We have not had as robust a coordination as Ethan just described. I think my gosh, we all have WhatsApp on our phone and various chats and Zooms and all these things. So it would be easy to do. We haven't really gone that far, unfortunately. The workaround though is we just have a lot. There's only 2 centers in town, mine and one other one, and we all know each other pretty well. So we do keep in touch informally. We did find a time early on, my military hospital, you guys probably heard about all these military hospitals being set up around the country in convention centers and football stadiums, et cetera. Well, a lot of those nurses came from our hospital. And so early on, there were times when we did not have personnel to operate at full capacity, but we did have 13 ECMO pumps and a lot of them were sitting idle. And so we were able to make some arrangements to loan those pumps to a local center who kind of had the inverse problem. They had enough staff, but not enough equipment. And so we were able to send equipment and disposables to the other center in town for probably 2.5 months there early on, until a lot of our personnel came back and we were able to ramp our program up at that point and brought that equipment back home. So that was pretty helpful. There is a WhatsApp chat that covers all the ECMO centers in Texas. Now, the metropolitan centers in Texas are far enough apart that they generally operate mostly independently, but I know Dallas definitely has some coordination. I'm not part of that, I don't live there, but there are some people who have used WhatsApp, just a simple chat room. And so not super formal, but a way to say, hey, I got a referral for a great candidate and I can't take them, can you? And so people have been successful in doing that, but it's more been loaning equipment. It has been our most successful aspect of regional coordination.
Thanks so much, Phil. Tammy?
Yeah, so at Mayo, we did not live through that first wave like most of the coastlines did. And I always say, I'm very fortunate. I work for Mayo Clinic, but we're a big hospital in the middle of a cornfield, folks. So we didn't really see COVID patients right at the beginning. And we waxed and waned throughout the summer. And so for our equipment, we own 9 cardio helps. We own, I think, 9 or 12 Centromegs. So we had plenty of circuits. But now as we have kind of hit wave 2 or wave 3, or however you want to look at it, it seems that as our numbers are starting to tick up, so is the metropolitan area. And so they've started this kind of consortium where the physicians will talk once a day and we will share our bed status. Like, okay, well, how many beds do you have open? And so now our medical director's also gotten on that phone call and said, okay, where are you with your ECMOs? How many ECMOs do you have? How many open ECMO beds do you have? And it's really allowed, I think, the best plan is when these patients come from our surrounding states, North Dakota, South Dakota, like where are we going to place that patient? Where is it best suited? Is it best suited to put them in Minneapolis, or is it best suited to come down to Mayo, Rochester? And, I hope that we can continue this consortium. It's nothing like what you had explained, Ethan, which I think I'm just like amazed at that. But it's a start in the right direction that we all start sharing our data, sharing what we can do and how we can help each other out as we navigate these challenges ahead.
Thanks, Tammy. While you're saying that, I just wanted to point people also, I'll go to Mike next, but also did provide us ECMO availability map. All of our centers have their status as red, yellow, or green. And I think that's trying to be as simple as possible, knowing all the variables that go into what ECMO availability really is comprised of. So if you haven't used that, it might be a nice quick visual just to take a look at your region of where there is availability, if people are using it. The data is stamped by the date it's last entered, so you can see if it's been a while. But anyway, just thought I'd point you to that. Mike, you have a really interesting point of view just around coordination because of the way you guys are organized in Chicago and especially your role. So interesting.
Oh, yeah. So like I said, the spoken hub model is really working well for us. And even though we have some part of the hubs or part of the spokes are not from the advocate hospital system, they still have an agreement to take care of the patients if they need to. And if not, they will try the second or third hospital like Northwestern or University of Chicago or Loyola or Evanston and see if somebody can handle a patient. The equipment wise, it was really tough at the beginning with oxygenators and all. And we had the fortunate, it was fortunate enough that Medtronic came out with the Nautilus oxygenator, which we were the first ones to try, which were getting similar performance to the Quadrox. So that was able to help us quite a bit. We were prepared to use our oxygenators from our heart-lung packs which are non-coated, non-PMP. And we've all dealt with that before where they start foaming up and all. That was very frustrating. Blenders, we had to acquire 50 blenders, but we could also just hook them up to the wall oxygen and hook them directly if we were fearful of that. In our unit, with the 25 beds, we have Stryker heat, they're blanket warmers. You could put up to 2 or 3 different connections on that. And when we had double patients, it was nice because we could have one heater cooler warming both patients on their oxygenators. So we also had to be mindful of our centromag. So each pod has about 10 beds, 8 to 10 beds, and we would put just one centromag console and motor in the corner of each pod, so we didn't have to have a second one on each room. So if we had a problem, we could just hurry up, run. It's maybe 15 feet away, bring it over to there and switch them out if we had to. We always have a prime circuit in our unit, at least 2 when we were at our peak of 25. We communicate with all the universities about what equipment they need. If there's any way we could help, if we could help them now, because we caught up with our supplies and equipment, and it really worked well. It's really nice, and we still communicate with all the guys in Chicago to see how they're doing and all. So that was our strategy and how we managed our equipment.
That's great. Thanks, Mike. Jen?
So yeah, in the beginning, we kind of have a similar experience to what Tammy shared. We didn't really have our first ECMO COVID until I think late June. So we kind of sat twiddling our thumbs for a little bit, kind of waiting for the sky to fall. And then we progressively got busier as the summer went on. But COVID did afford us the opportunity to sit down with the 2 other ECMO centers in the state of Iowa. They're kind of on the western half of things. And we, kind of tried to come up with collective selection criteria so that we were sharing the same information with all of the referral hospitals that we partner with. And every week we get on a Zoom meeting and kind of just discuss the pulse of everybody's hospital and kind of what their area is seeing, talk about positivity rates. We discuss ECMO numbers, how many patients do we have positive in-house, how many vented, how many proned, and then we do discuss our ECMO capacity. We actually have, we're partnering together to try to send out a broadcast to a lot of the referral hospitals with our collective ECMO criteria. We get a lot of, referrals from these much smaller hospitals that they obviously have no place to go with these patients, but unfortunately, a lot of times they've called too late kind of in the course of things. So trying to provide them with resources to set them up to be successful when they want to refer a patient. And then to try to coordinate that if, we have surged and we are, trying to keep a pump available for a potential transplant, then we can say, please reach out to hospital C or D and they can help you and we can kind of help facilitate that. So that's kind of been a nice way to kind of mend the bonds. We're no longer competitors. We're kind of here for the state of Iowa. We're not a very big hospital and we are surrounded by cornfields as well. So it's a challenge. Equipment wise, I do weekly inventory on our stuff and try to guesstimate really of when I need to place orders. And I don't want to say if I've had issues or not, because I'm going to jinx myself. That's a great way to have a recall or something like that happen, which we don't need right now. So, so far so good. That's all I'm going to say with that. So yeah, we've been fortunate in that arena.
Thanks, Jen. Tracy?
Yeah, so during the first surge, we started seeing patients come in needing ECMO with COVID at the end of March. And, we surged obviously through the month of May and then had a steady number of patients throughout the summer as well. Not quite as high as what we're seeing now. Now it's probably higher than any time so far. But what we did in the beginning, so we have in the state of Indiana, we're right in the middle with Indianapolis, and then we have partner hospitals within our system that are 1 to 2 hours away. And within those hospitals, we have CentraMag devices in our ECMO circuit so that if those centers are open heart programs, if they were to get into a trouble with a patient or, if they have a pulmonologist that thinks the patient's a candidate for ECMO and they need to cannulate there, they can, but they only have 2 devices per center. And disposables as well, just a low number of those. But we did in the beginning of the surge agree as a system to bring one of those devices down to the academic health center in Indianapolis so that we could have added depth for our devices. We also borrowed disposables in the beginning, and over the summer we were able to pay those debts back and put devices back to all but one so far. We still have one from our friends in Lafayette. And so that was sort of our initial approach of how to manage things. We've given those devices back because we are still doing open heart surgeries in those hospitals and need to have those rescue devices there. So we've just rented more equipment from Abbott. We've got more Centromag. We've looked at purchasing additional equipment right now to be able to increase our fleet to be able to support up to 17 patients is sort of our target number right now. I would say to the north of us, we've had several referrals from some centers in northern Indiana throughout this year, more than we've ever had. And so we've partnered with them specifically, related to disposables and also helping them get support from their administration to do ECMO and to be able to cannulate patients there if they need to, and then we can transfer the patient down. So I think, part of that is even pre-COVID, things that we would do, to support other centers to make sure that they can get patients what they need and then get them to our center for proper management after they're on. So that's a little bit about what we've done. We're also communicating daily with our transfer center to let them know what our capacity is for ECMO, because we're getting anywhere from 1 to up to 5 referrals a day for patients with COVID that might need ECMO. So we're just really trying to keep those lines of communication open, and as our patient revolving door spins, we want to keep everyone informed of what that looks like.
Thank you so much, Tracy. I know we're running up on time, so maybe I'll just close to say if there are, Liz sent a great message out a little bit ago, which is to say, if there are other things you want to have discussions on, please enter that as a topic suggestion in the chat, and we'll save this chat. But we'll schedule more meetings. It sounds like there's an interest, and then we'll look at how to expand capacity for this too. We tried to keep today a little bit not a webinar so everyone could see each other, but it looks like we hit capacity pretty quickly, and so there's probably more interest. So we may move to a webinar format next. We can still do that. It's just a little less, it's not as fast getting everyone on camera, so but that's okay. But I just wanted to thank all, especially our panelists who took time and prepared for your thoughts, what you wanted to share with the group. I think there's a lot more to add here from everybody that joined, both questions and suggestions for what they're doing themselves. So I'll just close by thanking all of our panelists and our team and everyone that spent time with us today. If you have suggestions for what else ELSO should be doing to support you, that's our role. That's why we're here. So please let us know, or let me know. You can email me csted@elso.org, and a variety of different avenues to communicate with us. So stay safe and healthy, and I hope everybody has a great weekend. And if I don't talk to all of you before the holiday, I hope you have some semblance of a holiday where you get at least a little break and a good meal. So thanks for all you do, everybody. Appreciate it.